Welcome and thank you for joining this paper presentation. My name is Florencia Grande and I am only a part of the scientific team from the Department of Health Informatics from Argentina. In this opportunity, I want to focus on some work related to some changes that during the first wave of COVID pandemic. So my presentation is about the design, implementation, and use of an electronic dashboard which provides monitoring of patients discharged home during a follow-up with telehealth consultations. The structure of this experience is based on 4 sections. The first one's introduction. I will try to explain why and what was the justification about this experience. Second, methods. We will explain how, when, and where we made this project. Third, results. We will discuss what about findings. Fourth, and the last one, discussion. We will focus on the so what, the interpretation, strengths, weakness, and generalization. Why is probably the most important message. This project was made during the first wave of the pandemic. In Argentina, the first case confirmed of COVID-19 was on March 4, 2020. On March 20th, we initiated the lockdown status. Until June, all patients with COVID received attention at hospital, with hospitalization, even those younger people or those with mild clinical symptoms. When outpatient management was finally enabled, asymptomatic cases or mild clinical symptoms start isolation at home with telehealth to follow up these patients. At the diagnosis, a video call consultation was scheduled between the physicians and patients. Based on the assessed clinical status of the patient during this first control, physicians can reschedule a second appointment for the next 24 or 72 hours, and so on. This remote surveillance of outpatients ended up to 10 days after the emergency department discharge. So, in this context, it was almost mandatory to make some evaluation on health outcomes related about quality and safety of patients. The primary aim of the emergency department was to create a real-time dashboard. They set the requirements by July 2020. Then the Biostatistic and Business Intelligence team analyzed several transactional systems for data collection. Finally, design and development was based using Pentaho as an extract, transform, and load tool, and we apply IBM Cognos Analytics. This figure 1 is showing us our dashboard prototype that corresponds a screenshot from April 2021. Every 44 hours, the system automatically updates the information, including so what the real-time data up to the previous day. Initially, the 3 most relevant indicators of the dashboard were A, this one here, that is the cumulative number of active outpatients being followed with telehealth, a total of 581 patients in this example. B, this one figure over here, that corresponds to the number of patients stratified day by day of follow-up, the count of patients from day 1 to day 14. And this information allows to visualize fluctuating epidemiological variations of confirmed cases. And see this one figure here that corresponds to the number of patients by insurance plan, information that we needed to organize human resources and the workflow. Because our hospital only guaranteed telemedicine follow-up for people affiliated with our private insurance plan with approximately 160,000 patients. It represents a quality measure about our telehealth provider. In practice, dashboard information behaves like a dynamic and prospective cohort of patients being followed up over the time. On the right side, the figure shows the increased number of cases per week during the first wave of the pandemic on 2020. After 14 days, discharged patients were withdrawn from the dashboard. On the left side, in this other figure, it was very easy to explore how many patients during 14 days of follow-up had a readmission at the emergency department, or how many were hospitalized, like a proxy of safety variable. In this example, from a total of 581, 109 and 27 respectively, representing 18% and 4% corresponding of April 2021. Regarding the quality of connection and satisfaction, we use an adaptation from a telehealth usability questionnaire after each teleconsultation. Patients answered that they could easily talk to the clinicians by using the telehealth system. Over 70% of question 1 answered like a Likert 7, and they were satisfied also with this telehealth system. Over 60% of question 2. Regarding discussion, we think that the main limitation is related to a single center experience. Despite this, we identify several strengths. It provides data quality, high data quality, users that were defined as physicians, researchers, or even decision makers, authorities. For them, all of them, it was very easily understood, the dashboard and the information, and they were able to track the outbreak. And finally, the data privacy and patient confidentiality were guaranteed, and the access to the dashboard was restricted. The topic in itself is so important given the context of the pandemic. In conclusion, we can say that we made an interactive dashboard which integrates metadata to visualize the information through important health indicators. The application of these dashboards had beneficial effects during the outpatient monitoring because during 14 days of follow-up, we evidenced a total cumulative incidence rate of ED readmissions about 13% and 7% of hospitalization rate. Users were able to manage the system of follow-up COVID-19 outpatients with real-time data. This information results crucial to optimize services and decision-making, as well to guarantee safety for patients. For example, the emergency department chief was able to decide how many physicians were needed day by day to make the follow-up according to the real data of number of cases. Probably, we describe an interesting solution for many institutions around the world during the pandemic, simply out of necessity, but easily and generalizable and reproducible. In this way, the use of BI to create an interactive dashboard can help decision making. Finally, I want to acknowledge to all collaborators who provide general support to the clinician research that are so many to mention here, but also to all health workers during the pandemic and our chief on internal medicine department for general support of this project. I will be available, of course, for any questions, comments, or suggestions via email. And thank you so much for your time.